Hi, everyone. My name is Dr. Michelle Henry. I am the founder and medical director of Skin and Aesthetic Surgery of Manhattan. I'm also a clinical instructor of dermatology at Weill Cornell Medical College. And I'm thrilled to be here for our social media event entitled Essential Updates for Skincare Providers Caring for a Diverse Population. And I'm thrilled to be here with my friend and colleague, Dr. Melissa Levin.
Hi, everyone. I'm Dr. Melissa Levin. I am the founder and medical director of Anterior Dermatology. I also teach at Mount Sinai. I'm a clinical assistant professor at the Icahn School of Medicine at Mount Sinai, and we're so excited for you to join us today. We're going to get through some cases.
Fantastic. So let's get started. So this is a common patient that we see in our office. So we're going to dive into some of the clinical features and let you know how we make this diagnosis, some of our kind of therapeutic ladder, what treatments we're using, both topically, laser, and procedures that we're using. So let's get started.
So, a patient comes into your office, she presents like this, Michelle. What are you basically first asking her in terms of her concern? How do you get that general history?
Yeah, so for this patient, she's a classic patient in our office, so we can kind of make this diagnosis from the door. But we do want to know how she got here, when she flared, and is this mild or severe for her? So I want to know how long she's had this, where is she in her life? Is she post-pregnancy? Is she taking any oral contraceptives? Is she someone who's postmenopausal and is now taking hormonal treatments? Because we know that all of those things can really flare or cause and trigger this condition. I want to know what treatments she's used before. I want to know her lifestyle. Like, is she outdoors a lot? Is she wearing sunscreen? What has she tried to treat this? So for us, this is really classically melasma. And we see these kind of brown patches. They can look kind of gray in certain patients. They're often on the central face. They can also present laterally. One good clinical point I like to mention is it often spares that periorbital area. And so that's really important to look at because there are other pigmentary conditions that can kind of present in this way. So the first thing you want to do is make that diagnosis, secure that diagnosis, and then you can start fleshing things out a little bit and talking about kind of her triggers. So does this get worse with the sun? Does this get worse with, it gets worse with infrared light? How is she living? Is it worse when she's in certain environments? Certain irritants can actually make this worse. So I go deep into what triggers does she have? What is she using? How is she exacerbating this at home? What good habits does she have? And what bad habits does she have before we start talking about specific treatments in terms of topicals, chemical peels, and lasers.
The other thing that I really love to highlight, I love that you talked about sun exposure. I also like to talk about heat exposure. With melasma, we know that it's triggered by infrared radiation and also heat as well. So I'll ask my patients, do they cook a lot? Do they bake a lot? Are they over like the oven?
Yeah.
Do they do a lot of, infrared, nowadays infrared saunas? Saunas are very popular. Hot yoga is very popular. And even if they are really good with sun protection, they may be going to warm, sunny places on a regular basis. We now have so many patients who are digital nomads. So getting that thorough history is very important. Once we go into that, then we go into what are they actually using? What is their current skincare routine? And I always say it's really important to go top to bottom. Exactly what are you doing in the morning for your skincare routine, and what are you doing at the end of the day? And sometimes folks are doing more than just skincare. They're taking supplements. They might be taking medication. So really getting that thorough history, both from their health history, their medications, their allergies, and their sensitivities. And once you can kind of understand exactly what they're doing, then you can understand what has responded really well. And besides that, what treatments have they gotten? She may have gotten chemical peels in the past or some sort of resurfacing lasers. She may have gotten a resurfacing laser that triggered or worsened the melasma. And also, like Michelle was mentioning in terms of, is this good or is this bad? Is she in the middle of a flare? Or is she in the middle of kind of her regular melasma condition? And melasma, as we know, is a chronic pigmentary condition that not only requires very unique treatment considerations for acute, more flares, as well as chronic, more maintenance phase as well. So Michelle, what are your favorite ingredients for melasma patients like this one?
So I absolutely start with skincare. As we said, melasma is very persnickety. It's very fussy. Lots of things can cause it to flare. Again, heat, UV radiation, even mechanical trauma can worsen it. So we want to be really, really careful with melasma. So I always start with skincare because it is the least likely to cause side effects. One of my mainstay treatments is still hydroquinone.
Same.
I use a lot of hydroquinone. Now, there's a lot of public pushback on hydroquinone because of misuse and abuses over the years. And hydroquinone is an irritant in and of itself. So a lot of patients just cannot tolerate hydroquinone. But if a patient can tolerate hydroquinone, it's a responsible patient that I know will use it for a short period of time, I will start with hydroquinone. Other ingredients that I love niacinamide. I will use niacinamide. I think it complements a lot of ingredients like hydroquinone really well because there are many different pathways. And what's interesting about hydroquinone is that it works in a different pathway what's interesting about niacinamide is that it works from a different pathway than hydroquinone, which is a tyrosinase inhibitor. Niacinamide will instead stop that transfer of the melanin from the melanocytes to the keratinocytes. So it's really great. It pairs well with that. I love azelaic acid. I love ingredients like arbutin, kojic acid, tranexamic acid. I like licorice extract. You'll see that a lot in some products. That's a great product you'll see over the counter. You'll see that added to a lot of your your fade creams and kind of lightening complexes. Vitamin C is great as well. So I love vitamin C. But hydroquinone, especially in office, is going to be my mainstay. And then for maintenance, I will add a lot of those other ingredients.
I love that you talked about tyrosinase. Tyrosinase is an enzyme that obviously makes pigmentation, revs that up. I also really like retinoids. Retinoids do block tyrosinase, but really the mainstay of a retinoid or retinol is basically increasing that epidermal turnover. So you're kind of exfoliating those pigmented cells a bit quicker. But beyond that, we also use a lot of alpha hydroxy acids, right? So alpha hydroxy acids like glycolic acid, lactic acid, these are really beneficial also in terms of that exfoliation and helping with pigmentation as well. Tranexamic acid is a great ingredient that you mentioned. I also really like cysteamine. Cysteamine is also another ingredient that we use more so for maybe the maintenance phase, or perhaps if we see a client early enough, we might prep their skin with that instead of what historically we used to do with hydroquinone. So I love putting patients on cysteamine, and that kind of blocks pigmentation in multiple pathways as well.
So I love that you mentioned cysteamine. So another fantastic use for cysteamine is to really just have it in the background of everything you're doing. So the hallmark of melasma is recurrence. And I have a lot of patients that come in and they say, I won't use hydroquinone, I won't use this product. I rebound immediately when I stop. And so I find that it's really nice to have something on the background that they can continue to use after they've stopped their hydroquinone, which we're going to use for a really short period of time.
So I love that you mentioned cysteamine kind of as a maintenance that they can use between flares, but also in between procedures. What are your go-to procedures for a patient who presents like this to your office, or what you would recommend an esthetician to grab for?
Yeah, so one of the first things, again, we're thinking about melasma. Again, it's persnickety, it's fussy, so you want to use those things that are going to introduce the least energy, right? The least trauma. So I really love chemical peels. That's a first step. And that's kind of a natural transition from using your retinoids, using your glycolic acid, those things that are causing that exfoliation. With a chemical peel, we're going to cause deeper exfoliation to really get rid of those deeper layers of pigment. Now, we're looking at specifically skin of color. We want to be careful with our peels. So I'm going to start with, lower concentration glycolic acid. Salicylic acid, lactic acid is safe. Mandelic acid is safe. Lower concentrations of TCA. So I'm keeping it below 10%. So it's become really popular to use these higher concentrations of TCA. When you're dealing with skin of color, I would stick to 5 to 10%, not much higher than that, especially for a first-time patient. You're doing your peels, again, you're going to need multiple treatments. It's a commitment and it's a journey. So I usually tell my patients, we're going to come in monthly, we're going to need anywhere from 2 to 6. And they say that's a wide range, but I say I'll know better when I see how you respond from the first treatment. But really to set their expectations and let them understand this is a difficult treatment, this is a difficult condition to treat. It requires commitment. It requires consistency, but chemical peels are definitely my next step. And I know that you do a lot of peels too. After peels, let's say a patient is resistant to peels, what would your next step be?
So I really like a non-ablative resurfacing laser. 1927 thulium is pretty much our go-to in terms of a safe wavelength that is really just right at the border of the epidermis and the dermis, so that we do get a little bit of a pigment kind of release, but also turnover of the skin. But you want to make sure that you're not doing multiple passes, very low percentage, and just like you said, more treatments, and they come back more frequently, and giving them a range is really helpful. I find that sometimes they come in, they were previously committed to 6, they got laser fatigue. Sometimes these lasers or any treatment that we do for melasma, because it can flare, the treatments in itself can make them flare as well. So really that counseling and laying expectations is really important as well. Besides chemical peel, non-ablative resurfacing lasers, what's another treatment that you do for our melasma patients?
So a laser that I use a lot in my office, and it really is a workhorse because I'm seeing so much pigment, it's a picosecond laser. So what I love about the picosecond lasers is they're applying that energy. So when we're doing lasers are based on the theory of selective photothermolysis. So we're getting that energy in there for our target, long enough to cause damage, but not so long that you're going to get collateral damage.
Correct.
And so what we get with the picosecond lasers, we're getting that energy in at the level that we want, and we're not getting that collateral heat, and just doing it quickly in a picosecond. So that's a laser that if you're seeing lots of patients of color, it's a great device to have. And so what it's doing is it's doing this kind of subcellular destruction. So it's actually destroying the melanosome, destroying those melanocytes, so without destroying the cell itself. So there's very little downtime. It damages using kind of like energy and sound. It's kind of like a photoacoustic damage. And then the immune system will take those cells. So I love it as a great safety profile for these patients. It requires multiple treatments. In some places they call it laser toning, right? Because it's low energy, but it's that constant low energy damage to the cells. So I really love that for my patients.
Many of our estheticians, they do have access to like a 1064 or kind of laser toning. Do you recommend that for a patient like this, or not necessarily?
So for a patient like this, you can. So I would stick with either a picosecond, or there are some longer pulse that you can get down to a microsecond. So like there's a device that has a 650 microsecond pulse duration. That's really great for these patients. I do also like resurfacing as well. I think I love that the thulium is going to be the mainstay. There's also a low energy diode, 1927, that is not as effective, but also has a good safety profile that we can use as well. But those are kind of like where I live.
So as a recap for a melasma patient like this, really robust skincare. That's the mainstay. Not that sexy, but that's really where estheticians shine. Also in-office procedures, light superficial chemical peels, 1927, whether it's a thulium or a diode resurfacing laser, maybe a picosecond, maybe a 1064 for laser toning, and really kind of that maintenance versus flare stage.
Exactly. It's all about, accessing that target with the least amount of collateral damage. Whether it is a peel or a laser, it's going to be about reducing your energy, reducing your density, and having multiple treatments. It's a journey.
That's for sure.
All right, so we have our second case. So this is a case that you're going to see a lot in your chair. So this is an acne patient. These patients often come in, a lot of patients of color come in saying, I have so much acne scarring. And it's up to you to determine, is this a true scar or is this post-inflammatory hyperpigmentation? So this is a patient that I would see in my office a lot. She would say, I have a ton of acne scarring, but what you guys see here is a lot of post-inflammatory hyperpigmentation. We actually don't see a ton of texture. We also don't see a ton of active acne. So this is a perfect patient for you to treat. And so this patient is going to respond beautifully to topicals. There's a lot of overlap in terms of ingredients between post-inflammatory hyperpigmentation and melasma. This is a patient that's going to respond beautifully to chemical peels as well. Again, this patient has darker skin than our prior patient. So you want to think a little bit about their response. So maybe even doing a test spot. It never hurts to do a test spot. And I find that a lot of your patients of color really respect that. And they respect the fact that you are taking that second step to keep them safe. And I find there's not a ton of pushback. They've had bad experiences in the past. And if you're positioning yourself as an expert in their skin, they want to know that you're taking this seriously and that you are really respecting the melanin. So again, I would start with topicals with this patient. I would then likely move to chemical peels unless they've used it before and have had a bad experience. this is a lot easier to treat than melasma.
A lot.
So, so your prognosis for this patient is going to be a lot better.
Yeah.
What else are you doing for these
I mean,
patients?
I think I really like patients to understand like their morning routine and their
Hmm.
nighttime
Hmm.
routine. And I actually will write it down for them
Hmm.
step by step. Your morning routine is really focused on protection. That's with robust antioxidants.
Hmm.
Patients oftentimes they know vitamin C, but now there are many different types of antioxidants that kind of
Hmm.
neutralize free radicals that really accelerate pigmentation, offer better protection for
Hmm.
infrared, for heat, for pollution, for blue light. All of these triggers can worsen pigmentation.
Hmm.
And then finding a proper sunscreen,
Hmm.
right? For a skin type like this, maybe historically in the past, she's struggled with finding a sunscreen that she'll incorporate for a daily use.
Hmm.
So many elegant options. Patients now sometimes are a little bit fearful of chemical blockers, even though they shouldn't, but there are beautiful options for physical blockers if that's what the patient wants. And it's your job to help them find that right product for them.
Hmm.
At nighttime, we had previously mentioned all these different great ingredients that we can use for pigmentation. I really love a retinol or retinoids for a patient like this. One, it helps maintain the clearance of their acne, but it also helps with their pigmentation as well.
Hmm.
Besides chemical peel, it's kind of similar with what we
Yeah.
talked about with that melasma patient. I really like a 1927 thulium resurfacing laser as well. Patients can do really well if they do have some textural change. Now, I don't appreciate this in the photo. She may have some light textural change. Then you can think about a light resurfacing laser, non-ablative. You can also think about microneedling for patients like this, but have them understand that the microneedling is more of a collagen induction therapy. That's what we used to call it, more so for textural scars, pitted scars, rather than pure pigmentation.
Absolutely. And rare is a patient that has this much hyperpigmentation and doesn't have some textural issues.
Correct.
So microneedling will ultimately be a part of your treatment, even if you're predominantly treating the hyperpigmentation first. So yeah, that's really important as well. I think what's also really important, we talked about sunscreen and prevention. I love how you said that we have many other options. I always tell my patients, it is an amazing time to be alive for sunscreen. We have every formulation out there. We even have completely mineral sunscreens that still look beautiful.
Right.
Some of them come in compact, some of them come as powder. So we have many, many, many different variations. So if your patient says, I've tried sunscreens, it doesn't work for me, there's a sunscreen out there for them. There are many different options. So prevention is important. So you also want to talk to your patient about what caused this, So is it acne? Was it something that they did that caused them to break out? So prevention is so critical when especially in that maintenance phase of their skincare journey.
I love that you called that out, because if you look at the distribution of her pigmentation, it's actually, there is a lot of concentration on the forehead. And even though she might be a teen or she might be a young woman, there could be some hair care behaviors that they're doing that can cause occlusion, that can cause what we call like acne mechanica. So I think it's really important to kind of understand, is there something that they're doing in their lifestyle that we can help modify?
Absolutely. So especially a lot of patients of color are going to be using heavier products that may include ingredients like petrolatum. And while petrolatum itself, we say it's not comedogenic, it is going to help to occlude many other ingredients that can lead to acne. So talking about their skincare, talking about how they sleep at night, do you pull your hair off of your face? What kind of pillows are you using? Really taking that holistic approach to prevent the problem while you're treating it, because again, it's a journey and maintenance is so important. So
I think we have a different acne case. Let's get
do.
into that one.
Yeah, so this is very different, right? So this is a patient, when we look at her, we're seeing a different distribution. We're seeing very robust acne. We're seeing lots of cysts and nodules. We're seeing a type of acne that if it's not treated appropriately can lead to long-standing scars. And especially when we're talking about a skin of color population, those scars can last for decades. The hyperpigmentation can last for years. There's some data showing that on average in skin of color, if it's not treated, PIH can last 5+ years. When historically the data said it can last for about a year, we're seeing 5+ years. So it's really important to treat this acne appropriately and not just treat the sequelae of the acne, or you're not doing what's best for your patient. When we look at this patient, the distribution also tells us that it's very likely hormonal. And most hormonal acne is treated best with oral therapies with a dermatologist. So this is the kind of patient that I would say quickly refer to your dermatologist of choice. And of course, once you get this under control, they're going to need maintenance because hormonal acne is very difficult to treat.
I think the other thing to keep in mind is that sometimes your clients may think that the only oral therapy is isotretinoin, and that may not be a medication that they're interested in, but there are many other oral therapies. I actually don't use a ton of isotretinoin in my practice, and the majority of what I see is adult female acne. We are so comfortable treating that. We want our estheticians to know that we are partners for this patient. The other thing that I like to call out is that please don't perform acne surgery or extractions on patients like this. This can actually worsen them. It can cause worsening inflammation and infection sometimes. Let us handle it. Let us do our injections, whatever that we need to do, put him on oral therapy, and then of course a topical routine. We are here to care for patients as a team together.
Absolutely. And I love that you brought up acne surgery. I think that in many states, estheticians are not allowed to pierce the skin to do acne surgery. That actually makes it quite more dangerous because the amount of pressure that's required to extrude the contents of that cyst, it's much higher and you're much more likely to create hyperpigmentation. And then if you are puncturing those areas and it's not done appropriately with the right tools in the right setting, then of course, infection, scarring, and a ton of other problems. So this is something that I would refer to a dermatologist quickly. And then of course we transition them back for maintenance because this is a long journey.
It's a tough case.
It's a very, very tough case, but needs to be treated quickly so that the patient is not suffering again from those really negative and severe sequelae of the acne. Another really tough case. And so this is the importance of teamwork and the importance of all of us working as diagnosticians for these patients. So what we're seeing here, to an untrained eye, this would be ruled out as post-inflammatory hyperpigmentation. But if you really look at this case, the nature of the pigment is a little bit different, and the distribution of the pigment is a little bit different. So when we look at it, we're seeing that we're really only seeing pigment specifically in the scars, at the base of the scars, right? And in deeper scars. Not just, when you're looking at standard hyperpigmentation, you're gonna see some pigment in the scars. You're gonna see some pigment adjacent to the scars. You're gonna see some pigment in areas where you don't see pitted scars. When you're really just seeing pigment in scars on a patient that is specifically using minocycline, you have to consider minocycline-induced hyperpigmentation, of which there are 4 categories. So you can see it in the scars, you can see it on the shins. Minocycline can really cause a lot of pigment, and we see it in 3 to almost 15% of patients. So it's not that uncommon. So when you're seeing this, if something about the pigment triggers you, this is a patient that needs to see a dermatologist so that we can give them adequate and appropriate treatments.
Just as background, minocycline is an antibiotic. I mean, we used to use so many antibiotics for our patients for the treatment of acne. And minocycline was kind of like our knee-jerk antibiotic that we gave to so many patients. And now we don't use minocycline as much. Some folks still use it. There are other oral antibiotics that we use when we really need to calm an acne flare down. But I always tell estheticians, trust your gut. You've seen a lot of post-inflammatory hyperpigmentation. You've seen a lot of melasma. When the pigment presents in a different kind of distribution, whether it's localized in scars, if the color is a little bit different, there are many different medications that can cause unique hyperpigmentation that is not your classic post-inflammatory or just photoaging of the skin.
Exactly.
And in that case, you really need a dermatologist,
Yeah, and it's really important also to understand that patients are getting their medications in many places. So you're right, dermatologists aren't using minocycline as much. There are many other antibiotics, newer antibiotics, hormonal treatments that we're using, but they're not always getting their medications from dermatologists. They can source them online. They can get them from different practitioners who may not know that history of minocycline. So this is a great place where you can serve your patient by saying, hey, are you taking minocycline? Maybe bring this up with your dermatologist, family practitioner, person online, whoever's giving you this medication. So this is a great place where we can really work together to treat patients, because this kind of pigment is very difficult to treat. It's not going to do beautifully with a lot of the topicals we use for PAH. Also something to think about if you're treating a patient with PAH and it's just wildly resistant. When I say PAH, again, I mean post-inflammatory hyperpigmentation. This is something that in my office, I treat it with a Q-switch laser, which is a laser that's going to help to shatter and help you shed and help your body clear this pigment. And I find that to be one of the best ways to treat this really difficult, resistant pigment. I would stay away from a lot of other treatments. The data really supports using the Q-switch laser, so it's not something you want to IPL in your office. It's not something that I find moves with chemical peels. This is where you need someone with expertise in treating these sorts of lesions.
So we went through really helpful cases. I think like 2 things to drive home when we're talking about doing treatments in skin of color patient. One, you could feel really uncomfortable with treating skin of color patients and basically back away and not treat them at all. And that does them a disservice because they're not getting the appropriate care.
Exactly.
So knowing when to manage and refer out, but also then to not be too aggressive, right? Not too much heat, not too many passes, making sure that you're assessing the skin before doing any treatment, getting a proper history, a thorough history, and then their pre and post care.
Exactly. And I want to underscore that again. You know, a lot of skin of color patients come in fatigued. They've been everywhere. Nothing works for me. And so while we want you guys to be careful, respect the melanin in the skin, understand what can happen and how uniquely sensitive it really can be, we do them a disservice by having them invest their time, the emotional effort it takes to have these treatments, and not feeling comfortable to treat them adequately. So if you get to a place where what you're doing isn't working, feel comfortable to refer them out so that we can work together. Because at the end of the day, what we all want is excellent patient care.
Well, always a great discussion with you, Michelle. I'm so glad that we did this social media event, and thank you for all our viewers for joining with us. We hope this was helpful.